Hi, my name is Lee Frost, and I am a community leader with Patients Like Me. And I am here to do a talk for PTSD Awareness Month about the biology of trauma and the principles of trauma-informed care. On the agenda, we have an overview of the differences between post-traumatic stress disorder and complex post-traumatic stress disorder, the principles of trauma-informed care, and some helpful resources that you can use on the Patients Like Me platform. So to kick us off, we'll look at the overview between the differences of PTSD and CPTSD. Post-traumatic stress disorder is the result of a short-term trauma. It can occur at any time in life and is usually the result of an accident, an assault, combat, and so on. It was added to the Diagnostic and Statistical Manual of Mental Disorders, also known as the DSM, in 1980. At the time it was added, it was primarily associated with combat veterans, and it took a while for it to be recognized as a diagnosis among those who experienced domestic violence or other traumatic event. CPTSD, or complex post-traumatic stress disorder, is the result of sustained long-term trauma that occurs over the course of years. Judith Herman was the first psychiatrist and scholar to propose CPTSD as its own disorder around 1990. She's the author of a book called Trauma and Recovery and is a pioneer in what is now a growing movement to work with complex trauma. CPTSD is internationally recognized on the International Classification of Diseases, but it is still not on the DSM list in the United States. Methods of diagnosis vary, but the Adverse Childhood Experience Test is a key indicator in how a chaotic and abusive environment can affect someone. The ACE test is made up of 10 questions about someone's childhood, and it covers the types of abuse someone may have experienced, whether they lived in poverty, or if there was addiction or mental illness in the household, and a number of other related questions. Studies have shown that people with high ACE scores are strongly associated with a reduced life expectancy of nearly 20 years. CPTSD is also differentiated by additional characteristics such as chronic medical problems, emotional dysregulation, a diminished sense of self, this is self-esteem issues, and relational issues. It's often been misdiagnosed as borderline personality disorder or bipolar. And ADHD is considered kind of a package deal with it. It's thought to be part of hypervigilance because the nervous system is on high alert all the time. It is really hard to stay focused. So to give you a visual, on the left side here, we have the core symptoms of PTSD: hypervigilance, avoidance, and flashbacks. And just to say a word about flashbacks, they're not as clear-cut or literal as is often shown in movies, especially with CPTSD. Triggers can come in many forms and be subtle. You may not even know why a flashback is happening, but the nervous system is reacting. Some people don't even remember their trauma and go into flashback mode without even understanding why. And on the right side, we have the additional symptoms of CPTSD. This is difficulty regulating emotions, feelings of shame or guilt, and trouble staying in relationships. And this is more than romantic relationships. This can be friends, families, and coworkers. Difficulty regulating emotions can be expanded into even identifying emotions. A lot of people with complex trauma have trouble explaining how they feel. The trauma is stored in the body, and what we feel is not easily described. There are some additional aspects of CPTSD, such as a tyrannical inner critic, which is often repeats of things that were told in abusive situations. So think of parents and emotional abuse. These kinds of things just keep playing out in the head over and over again. And there is a connection between the inner critic and the inner child. The inner critic is usually a fierce protector of the inner child. And there's a therapy called internal family systems that is great at breaking this down and giving practical exercises in overcoming these effects. CPTSD is also associated with social anxiety, hyperindependence, which means we have trouble asking for help, frequent nightmares, and sleep disturbances, among all these other things. And this is a quote from Bessel van der Kolk, author of Body Keeps Score, also an early researcher in complex trauma. Dissociation is the essence of trauma. The overwhelming experience is split off and fragmented so that emotions, sounds, images, thoughts, and physical sensations related to the trauma take on a life of their own. The sensory fragments of memory intrude into the present where they are literally relived. As long as the trauma is not resolved, the stress hormones the body secretes to protect itself keep circulating, and the defensive movements and emotional responses keep getting played out. Dissociation manifests in many ways, and every individual's experience is unique. One of the most common forms is depersonalization and derealization disorder. It's especially prevalent among children and younger people, but it can last a lifetime. And dissociation is also a common coping mechanism in people living with chronic pain. Depersonalization is feeling that the self isn't real, and it can also feel like you're observing yourself from an external point in the room. Derealization is feeling like the world around you isn't real. And this can manifest in feeling spaced out, not being able to track conversation or what's going on around you, shifts in behavior and character, and retreating to inner worlds. There's been some really exciting new research about complex trauma. A paper was published in 2023 that demonstrates that traumatic memories are actually encoded differently in the brain. The study involved the brain scans of 28 people living with post-traumatic stress disorder. And while this is a small study, the results were significant. They recorded sad, neutral, and traumatic memories to be played back while people were hooked up to imaging equipment. And the sad and neutral memories were shown to engage the hippocampus, the part of the brain that organizes and contextualizes memories. And the hippocampus was not involved in recounting traumatic memories. The researcher involved explained that this is not a state of memory, but it was a state of lived experience. The traumatic memories actually engaged an area of the brain called the posterior cingulate cortex, which is involved in internally directed thought like introspection or daydreaming. You can think about this like the brain being a library, and you have a set of books that are memories, and they should be stored in one area. However, the books with the traumatic memories are stored in another area of the library. And so as you recover, part of the job is to bring those books back to the central location where they belong. And the exciting part about this research is that a lot of research involving PTSD has looked at the fear center of the brain, the amygdala. And so this gives us insight into how other areas of the brain are involved in trauma. So to give you a visual about this, the hippocampus and amygdala are located in this lower central part here with the fear center of the brain. And in people living with trauma, the prefrontal cortex, where executive function lives, is also diminished in function. This is executive function, planning, prioritizing, organizing, task initiation, working memory, impulse control, and time management. And up here, we have the posterior cingulate cortex in the upper right here, and that is internally directed cognition and regulates the focus of attention, and that is where the traumatic memories are often encoded. You may have heard of fight or flight. There are actually 4 Fs: fight, flight, freeze, and fawn. And these are some of the characteristics associated with each type. And there could be hybrid types of this. So these descriptions come from Pete Walker's book on CPTSD called From Surviving to Thriving. And he goes into deep profiles of his clients so you can get a full portrait of what each personality type is like. And CPTSD is a dynamic disability in that this can shift over time. Your personality may be flight or freeze for a long time, but in certain situations go into fight or fawn. It all can change over the course of a lifetime or situation by situation. What we're ultimately talking about here is a dysregulated nervous system. This is a picture of the vagus nerve. It is the longest cranial nerve in the body, and it goes down and interacts with all of your major organs. And if you think about what it's like, if you've ever felt anxiety or chronic stress, you have very real physical symptoms. You may experience dry mouth or trouble breathing. Your breathing may be rapid and shallow, or you're holding your breath. There can be changes in your heart rate. There can be temperature changes. You may feel flushed hot or go cold. It can also cause digestive problems and feeling sick. This is all due to stress hormones. And the vagus nerve is part of the autonomic nervous system. There are two major branches. The sympathetic nervous system is the system of action. It is filled with chaotic energy. It's mobilized to attack. This is the fight or flight drive. And in the parasympathetic nervous system, we have two branches. We have the most sophisticated branch. This is the ventral vagal system. This is unique to us as humans. It's the system of connection. It's meeting the demands of the day, being able to connect and communicate, to go with the flow and engage with life. On the other side, we have the most primitive nervous system, which is the dorsal vagal system. This is the system of shutdown. It's also known as functional freeze or being in survival mode. This is just going through the motions. This is feeling drained of energy, being disconnected, dissociated, and is often involved with depression. So ultimately, when we're talking about trauma, we're talking about a dysregulated nervous system that is under chronic stress. It's hard to focus because your nervous system is on high alert all the time. Think of a guard in this watchtower in this picture. He's on high alert, he's amped up on coffee, stressed out, and he's ringing that alarm bell 24/7 until he collapses. Eventually, he pops back up and the cycle starts all over again. Until we learn how to befriend our nervous system and learn how to actively tune in and work with it, this cycle keeps going and stress hormones keep flooding the zone, which have very real physical effects. This quote, our story and how we think, feel, and act begins with neuroception. This is from Deb Dana, author of Anchored. This is the foundation of somatic therapy and polyvagal theory, which teaches us how to befriend and work with our nervous system. The window of tolerance is a common term used when talking about trauma and mental health. The just right space in the middle is small in people who live with trauma, and they can get stuck in the hot and cold zones where they switch between feeling overwhelmed and anxious to feeling fatigued and disconnected from the world. There are many ways about going about increasing that window of tolerance, from talk therapy, somatic therapy, EMDR, internal family systems, and other treatments can be used in any combination. The most important thing to understand is that building that capacity to better balance the window of tolerance takes time, patience, and effort to change how all of those internal processes work. It's a very individual path, which what works for one person may not work for another, which is why it's important to find community and share what works for you and support others on their healing journey. This is a concept called neuroplasticity, and this is a quote from Dan Siegel, professor of psychiatry at UCLA, where the attention goes, the neural firing flows, and the neural connection grows. With the concept of neuroplasticity, we understand that the patterns of behavior are wired into our brain and nervous system. But through these variety of treatments, we can change that wiring incrementally over time and actually physically establish new neural pathways that help us lead healthier, more regulated emotional lives. And here we are in part 2, Principles of Trauma-Informed Care. There are 6 principles of trauma-informed care: safety, trustworthiness and transparency, peer support and mutual help, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues. These 6 principles are actually not that difficult to put into practice. The essence of it is compassion and learning how to cultivate a sense of empathy to understand a patient's experience. It's about being transparent, why certain medical procedures or treatments may be recommended, what's expected in them, and explaining all the details and allowing for questions. The patient healthcare provider relationship should be one of collaboration and co-designing a treatment plan that will fit a person's lifestyle and the resources that they have access to. It's about helping someone feel empowered to be involved in their healthcare decisions and giving them a sense of agency so that they can integrate what works for them into their lives. As patients, we have every right to ask questions and request transparency at every opportunity. There should be no gatekeeping in trauma. From the perspective of the nervous system, there is no big T, little t trauma. If the nervous system is stuck in functional freeze mode, it doesn't matter what the cause is. You may hear people say things like, you didn't have it as bad as other people. I didn't have it as bad as other people. Those are gatekeeping statements. CPTSD is not always caused by physical abuse. Long-term sustained emotional trauma can result in CPTSD as well. And generational trauma can be passed on. This comes from the work of Mark Wolin, author of It Didn't Start With You, and Gabor Mate, The Myth of Normal. And trauma actually can be encoded in our DNA and passed on. People with disabilities and chronic illness should also have access to trauma-informed care. It takes an average of 10 years to be diagnosed with a rare disease and about the same amount of time to be diagnosed with endometriosis. This involves tons of appointments. It can involve being met with dismissive attitudes, medical gaslighting, wrangling with insurance companies, and that in itself can dysregulate the nervous system over time. And even living with a disability or chronic illness can be its own form of complex trauma. We do know from research that, for example, chronic pain does lead to a dysregulated nervous system. So when it comes to medical appointments, it's important to take a holistic view of the person's medical history. A constellation of seemingly unrelated symptoms can form a picture of chronic stress and trauma. So it's important to keep track of symptoms, identify patterns, keep your notes with you, and for healthcare providers to show patience. Shutdowns can happen, and going nonverbal comes easy to people living with CPTSD. There are quite a few medical problems that can come with it. So heart rate variability is out of sync in people who live with complex trauma. Heart rate variability measures the relative balance between the sympathetic and parasympathetic nervous systems. And that means that our breathing and our heart should be in coherence, and it isn't with people with CPTSD. This comes from the work of Bessel van der Kolk on the upper two. This is the heart rate variability in a well-regulated person. The top is just a normal situation where everything is in sync. And in the second one down, it's that person responding to an upsetting situation. Things are still more or less in sync. Whereas in the bottom, this is heart rate variability in someone living with PTSD. This is shallow, holding the breath, out of sync with the heart rate, and this is what causes a variety of illnesses over time. And it can manifest in any number of ways, from arthritis, asthma, autoimmune disorders, cardiovascular disorders, ME/CFS, chronic pain, diabetes, dysautonomia, endometriosis, fibromyalgia, and unfortunately, this is a short list. There are many ways that this can show up. It can be a collection of long-term chronic illnesses or a bunch of random things, any combination. And I just wanted to highlight reproductive issues. There's a strong correlation between severe physical abuse and gynecological problems. The connection is also dose-related, meaning that the chronic pain and symptoms correlate with the intensity of the abuse. Studies have shown that 79% of survivors develop endometriosis or other chronic pelvic problems. And women who experience chronic pain are more likely to use dissociation as a coping mechanism. Perimenopause is also harder for those living with CPTSD. Symptoms are more intense. chronic stress can lead to imbalances of estrogen. And so once perimenopause kicks in and you have all these fluctuations with estrogen, all of that can worsen. It's all part of this dysregulated nervous system. And finally, some helpful resources from the Patients Like Me platform. One of the things that I do is use the Daily Me to track mood trends. I also like to add what are called glimmers in the comments. These are small little moments that help train those neural pathways to focus on something positive. So it's going for a walk and seeing a beautiful sunset or making your favorite cup of tea. And so I can see over time maybe what kinds of patterns of behavior and where I may need to change how I work with my treatment. I also use the pain and fatigue rating scale because I do live with chronic pain. This is developed by patients like me to help monitor the severity of pain, fatigue, and sleep because they often work together. And this has been incredibly helpful for me to understand all these connections. I also enjoy community discussions. I've been a community leader for a little over a year now, and it's been really helpful to get advice and share learnings as I go in my own recovery journey. And finally, one of the other things that I love to use is the doctor visit guide. This is something that you can add to over time. So I add questions as I think of them and plan for how I want to make the most of every appointment that I have with my healthcare providers. So that brings us to the end of my presentation. And thank you for listening and thank you for having me here.
Haley, that was great. Thank you so much.
Sure.
Um, I actually have two questions, if that's okay. So, what's something that you should not say to someone with CPTSD? Or maybe a few things. Is there anything that comes to mind?
I think it's important for people to understand how embodied this is. This isn't just a matter of like, why can't you just get over your past? And that's
Hmm.
something I heard a lot growing up. It's like, oh, just learn to live with it. It's a very physical thing. And unfortunately, like when I was growing up, PTSD hadn't even been added to the manual yet. So we did not have this knowledge. So, and yeah, I still kind of see these comments from time to time because I'm very active on social media. So I think it's important to understand that this is a very physical, real thing that takes a lot of time and effort to overcome.
Thank you for explaining that. And then, how can loved ones support someone with CPTSD?
Oh, this is a great question. There are so many programs I've been in that actually have materials prepared for loved ones, caregivers, friends, and family. Um, it's really important to give people their space and to just be patient with them because as you're processing all of these traumatic memories, a lot of weird emotions come up. Like sometimes it's even the most innocuous memories somehow seem to be very triggering just because of their proximity to actual traumatic events. And so when someone is going through whatever types of therapy or modalities that they're using, there can be times where you feel really raw and rough and you just need time. And you might need a safe space in your house, just like a little corner of a room where you just need to sit and be. And it's not trying to shut other people out. It's just that this is really exhausting work and it just takes time.